We are live.
Good evening and welcome everybody to the DOS Postgraduate Education Program, DOS PEP as we all know it. And as you all know, we are currently on the in the Retina module of this DOS postgraduate program following the completion of our oculoplasty series. And we have, let me just share my screen. Yes. So currently today we are on the 8th class of the Retina module of the DOS postgraduate program. And the topic for today is central serous chorioretinopathy. We have with us the speaker for the day is Dr. Charu Gupta ma'am. And we are fortunate to have our chairperson, Dr. Lalit Verma sir, who's been coordinating this entire program, and Dr. Cyrus Shroff sir, who is today present to chair this class on CSR. I'm really thankful to you, sir, for being with us today. We also have had a recent collaboration with ANBI, wherein all the DNB students that are in association with the DNB hospitals have joined through this platform with us. Dr. Lalit Verma sir needs no introduction. He's been kind enough to formulate this retina module and suggest all the speakers and the topics for the classes. We are thankful to Dr. Anupam Sachdev sir, with whose coordination we've been able to have the ANBI collaboration with the Delhi Ophthalmological Society. Dr. Cyrus Shroff sir needs no introduction. He is a senior consultant of retina at the Shroff Eye Hospital in New Delhi. He has done his post-graduation from the prestigious RP Center for Ophthalmic Sciences, AIMS, New Delhi. He has also worked at Shankar Nethralaya. He is one of the first to introduce vitreous surgeries in North India. He's been an instructor, guest lecturer, and faculty at various national and international conferences, and has also received various awards in the American Society of Retinal Surgeons and has won the Red Buckler Award at the American Society of Retinal Specialists Film Festival on 2 occasions. Sir, it's been very kind of you to be here on this for this lecture. Dr. Charu Gupta, who's the speaker for today, she's a senior consultant of retina in Shroff Eye Hospital. She's done her MBBS and post-graduation both from the prestigious Maulana Azad Medical College, New Delhi, and Guru Nanak Eye Center. She has done a fellowship in vitreoretina from Arvind Eye Hospital, Madurai. She has presented at various national and international conferences, and we are fortunate that ma'am has been kind enough to give us this lecture on central serous chorioretinopathy, which is very important from postgraduate point of view because it comes as even short notes, long questions, and even on their practical exams, a lot of spot cases are kept for 90-day examination on CSC cases, if I'm right. So with that, I would like to hand over the dais and to Dr. Charu Gupta ma'am. Before that, sir, would you like to say a few words? Cyrus, sir? Sir, can you hear us?
Yeah, thank you, Pranita. And I think it's very good that DOS has taken this initiative under Dr. Lalit Verma's overall guidance for the retina module. And I think, as you mentioned, CSR is really a very important in medical retina, one of the most important things apart from diabetic retinopathy and AMD. I think it's probably the most important topic that, and CSR has a lot of variants and nuances, which I think Dr. Charu Gupta will be bringing out in the next few minutes. And I think she is in our retina group. I think she's the person who is the most well versed with the latest developments in this field, and also with the various nuances about the OCT angiography, and all the latest developments. So I think she is just the ideal person to be talking to us about this topic today. So over to you, Charu.
Ma'am, you can start sharing your slides, ma'am. Yes.
Yeah, thank you, Dr. Pranita and Dr. Cyrus, for the very kind introduction.
I think, and it's a very good initiative by the DOS to have a topic on CSR, because I think, yes, as we do come across it very regularly in our clinical practice, and yeah, and that's why the postgraduates do need to be aware of it. And with the changing imaging modalities, I think a lot of new things have happened in this field. So coming on to the other, we start from to introduce CSR. It is CSCR, which was earlier known as CSR, which is central serous retinopathy, which is characterized by a blister-like serous detachment of the neurosensory retina and the RPE at the posterior pole. Traditionally, it was always thought to be unilateral and only involving the retina. But with newer imaging modalities, pigmentary changes are often picked up even in the asymptomatic fellow eye, making it more bilateral, and the involvement of the choroid, especially with the swept source, has been proved beyond doubt. It is associated with relative preservation of central vision despite prolonged separation of the neurosensory retina from the RPE. So it is the fourth most common retinopathy, and most of us are aware that it is seen most commonly, as we say, in the young male, so age group of around 20 to 50 years with a male predominance, seen more in white and Asians rather than blacks. But I think, again, with the newer imaging modalities, and there's a paradigm shift. Probably now you have more patients who are diagnosed at 50 years or older, and they tend to have a decreased male predominance, and show more diffuse RPE changes. Uh, some of the risk factors associated, of course, most commonly is stress, and that's one of the things that we always tell the patients, we always counsel them about it. A type A personality, history of steroid intake, systemic in form of inhalers and creams. So it's very important to take a good history, because they are very often, we find that there's some form of steroid, either plant steroids, also some Ayurvedic medicine. So you always need to take a good history, so that you can get to the bottom of it. Hypercortisolism, pregnancy, obstructive sleep apnea is, again, I think sleep disturbances are increasing in the present generation, and this is again a very important history that you need to take. Hypermetropia, smoking, alcohol consumption, hypertension, and there's some evidence that it may be Helicobacter pylori also has some role. The pathogenesis is basically by an increased choroidal hyperpermeability. So one of the mechanisms that they have explained is the aldosterone mineralocorticoid pathway. That is, in preclinical animal models, they found that an intravitreal injection of aldosterone provoked vasodilation, thickening, and leakage of choroidal vessels and accumulation of the subretinal fluid, mimicking CSC. But the most common is that is a type A personality, raises the cortisol levels. The adrenergic reaction causes damage to the choriocapillaris, which in turn leads to hyperpermeability of the choriocapillaris. Simultaneously, there is RPE cell degeneration, and because of the secondary changes in the RPE causing leak, the fluid, if there is actually no degeneration of the RPE, the fluid will stay contained. But because the RPE is degenerated and there's a gap, and the fluid then accumulates between the potential space, that is between the neurosensory retina and the RPE. Well, typically, the most patients will come to you with a blurred vision, with a relative scotoma. So they'll always say it's a grayish and not a black area that they see. So they always say a grayish area in the central visual field. There's metamorphopsia and or micropsia, dyschromatopsia. So there's a color vision issue that is there. And most importantly, there's a hyperopic shift in the refraction. So, again, it's very important that the patient is saying a blurring of vision. The optometrist or the refraction would correct it to 6.6, but you need to be aware that you have to just check the fundus, and yes, you may otherwise miss a CSR. So patients with extrafoveal involvement are asymptomatic, and that's again something that over the period of time, that's very important, because we've learned that we need to follow up the other eye also carefully. So on fundus examination, typically an acute CSR patient, you'll see a well-circumscribed neurosensory detachment. It is very important to see all the margins all around, because not once, but very, very often, an inferior RD, which usually presents very slowly, can be missed because you haven't seen the inferior margin. And also that's why it's very good to do an indirect ophthalmoscopy and not see a patient only on the on the 90D or a slit lamp biomicroscopy. The other presentation could be a presence of fibrin, which can mimic a choroiditis, but here you present with an exudative RD, and the further imaging modalities will tell us the diagnosis. Sometimes there are very subtle presentations in chronic CSR. You just see some pigmentary changes as seen in the blue arrow here, which indicates a previous episode, or it can also indicate an asymptomatic fellow eye. So coming on to some of the definitions, acute CSCR is usually an NSD which resolves within 3 to 4 months. Chronic CSR, when the NSD persists beyond 3 to 6 months with associated pigmentary changes. Recurrent CSR, when there is a recurrence of the neurosensory detachment after a complete resolution. And atypical CSR, when the CSR is associated with an exudative detachment. So OCT is definitely the most important imaging modality. So when a patient comes to us, I think that's the first go-to imaging modality. It is because it's most widely available these days. So I think all our diagnosis and how we are going to further analyze the patient depends on how we interpret the OCT. And over a period of time, what we gain from an OCT or what we are able to interpret has really increased because of this EDI and the SWEP source. So typically, of course, you see a neurosensory detachment, but I think now over a period of time, the other things that you're looking for on an OCT. So you look at the choroid, you see an increased choroidal thickness, which is called pachychoroid. Pachy means thick, thick choroid. And how do you measure the pachychoroid? That is from the outer edge of the retina to the inner border of the sclera. Normal thickness is around 250 microns. Of course, it varies with age, time of the day, and many other factors. But anything more than 250 or 300, you are thinking of pachychoroid. Another presentation could be, that subtle yellow arrow showing a fibrin. So especially with steroid intake or with an acute CSR, you often find with the neurosensory detachment of a yellowish kind of lesion, and this is the fibrin. Again, these patients you have to rule out an inflammatory pathology in such situations. Another very common presentation with a neurosensory detachment is a serous clear PED. There is no hyperreflectivity inside the PED. So that is yet another presentation. Of course, coming on to chronics, those were presentations in acute CSCR, but you have patients with chronic CSR that has been present for over 6 months, and then the kind of OCT findings change. So you can see that the orange arrow is showing cystoid spaces, and these are very well circumscribed cystoid spaces in the outer plexiform layer, and if you see between those two triangles, there's disruption of the ellipsoid zone. There is again a feature that is very typically seen in chronic CSR. Then you see this shallow irregular PED or a double layer sign. But I think one common feature that you see are these pachy vessels that you see. So I think the Bailey-Franz group, actually, they kind of analyzed a lot of these cases, and they then said that the pachychoroid clinical spectrum is actually a group of macular disorders that manifest with similar choroidal findings. The definition of pachychoroid is continuing to evolve with the application of novel multimodal imaging modalities. It includes CSCR, pachychoroid pigment epithelopathy, which we will discuss, pachychoroid neovasculopathy, which we'll briefly come into, PCV or polypoidal choroidal vasculopathy, peripapillary pachychoroid, and sometimes focal choroidal excavation. So what are the common features? So it is a thickened choroid, which is usually the group mentioned more than 270, but now actually the thickness of the choroid is not important. But what's important is the presence of dilated choroidal vessels which are called as pachy vessels. They are dilated vessels in the Haller's layer. The presence of choriocapillaris and sattler layer attenuation occurring at the inner aspect of the so this is the pachy vessels, what you see in the star-like thing. So these are dilated choroidal vessels. And this is the attenuation of the choriocapillaris and the sattler layer. So, sorry. And the fundus usually has very reduced fundus tessellation. So coming on to pachychoroid pigment epithelopathy. Now, the top photographs that you see are basically a patient of an acute CSCR. You can see the pinpoint leak. You can see the fibrin that is there in the OCT here with the PED. But if you see this, the other eye, that's the fellow eye, there are only some subtle pigmentary changes that are there, or what you see as in this seen as mild hyperfluorescence. But what is the important feature is the choroidal thickness, even in an asymptomatic eye, is increased. It is around 360 microns, and you can see these dilated pachyvessels. So that's why it falls into the category of pachychoroid pigment epithelopathy. Here, the pigmentary changes are present with the choroidal features that are seen. And it often can get misdiagnosed as atypical ARMD or pattern dystrophy. So we need to be aware of this particular entity. And I think the more important thing is that sometimes this can then later on change into a pachychoroid neovasculopathy or go on to a CSR, or can go on to a PCV also. So FFA and CSR was definitely the gold standard imaging modality, say, the pre-OCT era before 2003. But now the indications have come down. It's indicated only if there's a diagnostic dilemma, in non-resolving recurrent cases, when early rehabilitation is required, when you're planning laser photocoagulation. So this is typically how a CSCR leak looks like. It's important in a CSCR to have the early phase, the mid phase, and the late phase. Why? Because you have to see how the leak kind of progresses through the angiography. So in the early phase, you can see that it starts as a small area, then it keeps increasing in intensity, and by the later phase, it tends to pool. This is another type of pattern which is less common but much more dramatic. So here the leak starts as a very small point, but it extends superiorly and then laterally, and then it sometimes fills up the entire area of the subretinal fluid, and it's called a smokestack pattern. The third pattern here is when you see it with a PED. Here there's an increase in the intensity, but the size remains the same. So this is a PED. Unlike a leak where it kind of it increases in size, here the leak stays within that area. So there's no increase in size, but there's an increase in intensity. In chronic CSR, you do not have these acute changes, but what you have are these subtle hyperfluorescence, which is basically window defects due to atrophic RPE changes. And sometimes you have block fluorescence due to some earlier laser marks, or you may have block fluorescence due to the presence of pigment. Another imaging modality that is seen that is used, but not, again, very rarely or only in certain diagnostic or difficult situations, and when you're planning a PDT or a photodynamic therapy, is ICG. It is important to do a ICG prior to PDT because it's seen that the area of choroidal vascular abnormalities is usually much more widespread than is picked up on the angiography. And you also can pick up findings in the other eye. So coming on to ICG, what are the various findings that you see? So this is the early phase of the ICG. Here you can see this hyperfluorescent area. It's because of the choroidal hyperperfusion. Later on, you have these dilated pachyvessels and areas of increased choroidal hyperpermeability. And by the later phase, there's a washout in the late phase. So when you're planning a PDT, see, this was a patient of recurrent CSR and it had a subfoveal leak. So if you were planning a PDT just on the basis of the angiography, you would probably treat a very small area. But if you do an ICG for the same patient, you realize that the area of choroidal hyperpermeability is much more widespread. And when you treat such a patient, you should be able to treat all the areas of choroidal hyperpermeability. Autofluorescence is again gaining in importance as an imaging modality over a period of time. I think the most important reason is it's non-invasive, and it helps us in knowing the functional status of the retina much better. So this is a patient of an early CSR, which is seen here. The neurosensory detachment is seen as a hyperfluorescent area, hyperautofluorescent area. As the CSR progresses to become chronic, because the lipofuscin deposit increases, you see it as more hyperautofluorescent. But interestingly, if you compare it to the angiography, here you can see a lovely teardrop pattern. So it's actually, if you were to just to see the autofluorescence, you can actually go back and know may be possible that get to know where the leak is. But the most important reason for autofluorescence, and that's what we need to probably know, is that it is pathognomic for chronic CSR. And these gravitational tracts that you see, they are basically hypoautofluorescent areas surrounded by hyperautofluorescence. And these are telltale signs of presence of CSR, and especially in sometimes when you're confused in your diagnosis that we'll come to later, these tracks can be very helpful. OCT is again an imaging modality which has come in vogue nowadays, and it's very important, the OCT, to detect a CNV in some of these patients. So to get to know that whether your CSR has a new vessel, because then the treatment becomes more defined and simpler. OCT-A will definitely help in picking up this new vessel. But otherwise, in chronic CSR, what you see are usually low flow signals, these dark areas, flow deficits, and flow rarefaction areas. So this is how a normal choriocapillaris with the honeycomb pattern should look like. But here you can see that there are a lot of these dark areas. So being aware, if you see the choriocapillaris layer, you can probably diagnose a case of chronic CSR. So this was a patient, a 57-year-old male patient with metamorphopsia, visual acuity of 612 and 8. And if you see, you can see this hyperautofluorescent area of fluid. You see these definite leaks here. And it looks like a definite CSR, but if you look carefully, you scroll the various areas. So when you look at an OCT, it's important to actually look at all the scans sometimes, especially if things are not corroborating. And here you see possibly that there is some hyperreflective area or a double layer sign, and a possibility of a neovascularization. So we do an OCT in this, and you do pick up this neovascular complex. So the pachychoroid spectrum, as we mentioned, it helps us to identify this conversion of a CSR or a pachychoroid pigment epitheliopathy to a pachychoroid neovasculopathy and a PCV. So this is a patient of a chronic CSR. You see this PED on the ICG. You see this PED on the FFA, the PED on the OCT. And over the period of time, that is 5 years, this has become hyperreflective. And when we do the OCT, you pick up this neovascular complex. Similarly, this is a patient, actually, he was screened for the other eye, had a quiescent network, nothing. This is pachychoroid pigment epitheliopathy. The patient is asymptomatic, but 5 years later, you realize that this patient has come with a polyp, which is confirmed on the ICG. So that's why we need to know all the various findings. You need to see these findings. You need to pick up these findings, and then that will help us to diagnose. But also it's important that not every NSD is a CSR. So sometimes you have, this is a NSD, sorry. Yeah, but if you see this RPE layer is not straight, there is the macular convexity is towards the vitreous cavity. So this is what we call as a dome-shaped maculopathy, which is seen most often in high myopes. Then sometimes you can have that there's a cupping or a pitting of the choroid near the macula without any scleral ectasia, which is called as a focal choroidal excavation, again seen more often in high myopes. Sorry, I think this got missed out somewhere. Anyway, sorry, I think we'll go ahead. But this is an optic dispit. Sometimes it actually is seen as a neurosensory detachment, but you should, especially if you have a CSR or a fluid-like thing, which is coming onto the optic nerve, onto the edge of the temporal aspect of the optic nerve, always look for the pit. This is another patient which has an NSD, but you see an RPE bump, and on the color photo, you see drusen. So this is not a CSR. If you see the angiography, again, you see the staining pattern of drusens. And on the OCTA, you see a nice network. So not every neurosensory detachment should be labeled as a CSR. So you need to look for other findings. So again, this is a patient who has a bilaterally symmetrical neurosensory detachment. Whenever it's bilaterally symmetrical, again, you need to keep the antennas open, and you need to think of more of iridomacular kind of degeneration. So again, if we see the color photo and we see the autofluorescence, you see the lipofuscin deposits, which are quite typical of West vitelliform degeneration. And you can do the electrophysiological test at this moment, I mean, to confirm your diagnosis, but this is a case of BESS and not CSR. Again, this is a patient of a neurosensory detachment, but if you see, the RPE is not straight. The RPE is pushed into the vitreous cavity. If you see the color photo, there's an orangish hue. The ICG shows a hypersenescence, which increases in the later phase and washes out. A case of choroidal hemangioma, which the treatment would be very different, but not very different because it is PDT, but you still need to know that this is a choroidal hemangioma. So this is a patient who on color photo looks, you can see this fluid that is there in both the eyes, could be a CSR, but you can see the disc. This is a disc edema. You see the OCT, again, there is a neurosensory detachment. So the treatment, this could be an inflammatory pathology, a white dart syndrome, or it could be a CSR. So what are the treatment we would like to do, what would be the imaging modality we'd like to do in this case? So we did an angiography and an ICG, and the disc edema, early hypofluorescence on the angiography, all of that confirm that this is a case of inflammatory pathology and not a CSR. You give steroids and the patient responds beautifully. It's very important to actually differentiate between the two, because steroids in a patient of CSR could be disastrous, while in a patient of an inflammatory pathology, it's the treatment. And this is actually very often the dilemma. So here we have another patient with an exudative detachment. You can see these orange arrows, there's an exudative detachment. And here there's a yellowish kind of a lesion. Is this choroiditis? You can see this hyperautofluorescence. This is the level of you can see the detachment in both the eyes. This could be shifting fluid. So is it an inflammatory pathology or is it CSR? When we did the OCT in this, you see these large pachyvessels that are there. There's an attenuation of the choriocapillaris. There's fibrin in this area. But the confirmation is on the ICG and the angiography. So there are these dilated choroidal vessels that you see, and on the angiography, you see these the multiple leaking points that are there, which increase in the later phase. So it's a multifocal CSR. So the treatment would be just focal laser to this, and we like to always add an anti-VEGF, combine it with an anti-VEGF to decrease the collateral damage. We did, of course, an OCTA to rule out a CNVM, because that yellowish lesion sometimes could be just SHREM and could be a CNVM. So multimodal imaging is key to diagnosing and staging CSCR. It guides its treatment and differentiates the disease from the broad range of other entities that may mimic CSC. So coming on to the management of CSR, the management is conservative, 80 to 90%. And that's very important that we realize that we don't need to rush into treatment for most CSCRs. 80 to 90% undergo spontaneous recovery by just reassuring the patient. Resolution is usually within 3 to 4 months. The visual recovery is very good. There's sometimes, or most times, mild metamorphopsia, faint scotoma, abnormalities in contrast sensitivity, and color vision may persist. Another important thing is the recurrences. So recurrences are seen in nearly 40 to 50% of patients. So counseling about this and reassuring that even if there's a recurrence, not to worry about it is important, because ultimately this disease is related to stress. So some of the things that we can emphasize during the conservative management is lifestyle modification, treatment of sleep apnea, psychosocial therapies. These may affect patients, especially who are prone to psychological stress. That should be, if their patient is on steroids, discontinuation of steroids of any form is advocated. And endocrinologist's opinion, if any doubt of hypercortisolism, is important. So one of the main, the easiest way of a treatment protocol could be focal laser photocoagulation. So focal laser photocoagulation is indicated when there's an extrafoveal leak. So if the leak is subfoveal, we cannot, because we'll cause much more damage. But if there's an extrafoveal leak, you can treat it with just a focal laser, and it induces a direct thermal sealing effect on the focal RPE defects. It's indicated in recurrent CSR, if the fellow eye has a permanent visual deficit, if some patients like pilots who want early restoration of vision, and in chronic CSCR. A recent FA, so if before any focal laser, it's important to have an FA within the 7 to 10 days of the, I mean, if you're planning a laser, the FA should not be more than 7 to 10 days old because, it is a dynamic disease. So the area of leak may vary. And we prefer combining with an anti-VEGF so as to prevent any risk of collateral damage and CNVM formation. So this is a patient of CSCR. On the OCT, you see basically a dilated pachyvessels, this increased choroidal thickness. This is the NSD. This is the autofluorescence, which is showing the area of the fluid. These are the arrows showing the leak. And post-treatment, with focal laser and anti-VEGF, the fluid has settled down, the leak has disappeared on the follow-up FA. The patient has done pretty well. So I think timely treatment, and I think we found combining with anti-VEGF does help. This is a patient of chronic CSCR with multifocal leaks. So they are these orange arrows showing multifocal leaks. Very nice gravitational tracks in this patient suggesting chronic CSCR. Of course, the thickness is 553. The other eye was very poor vision due to earlier attack and sick RPE. So this patient, we advised focal laser, did very well. The choroidal thickness has decreased from 553 to 409. The leaks have disappeared on the check angiography, which is done usually 2 to 3 months after the treatment. And but of course, we need to follow up such patients because, as I mentioned, that recurrences are quite common. Another important treatment modality, or possibly the best treatment modality, unfortunately, but not available these days, is PDT. It is advocated for acute CSCR with subfoveal leak, non-resolving CSR, and chronic CSCR. The mechanism of action of PDT includes the induction of choroidal hyperperfusion and choroidal vascular remodeling, which is presumed to be beneficial for the hyperperfused and hyperpermeable thickened choroid in typical CSC. The PLACE trial and many other large retrospective studies on PDT for chronic CSCR have shown efficacy, safety, and favorable visual outcomes of ICGA-guided PDT with complete resolution of SRF after treatment in nearly 60 to 100% of eyes. Both half fluence and half dose have been found to be superior to the standard dose. So the standard dose, the disadvantage is it can cause a lot more pigmentary atrophic changes. So we always prefer, unlike in other indications, we prefer half fluence or half dose. Both do equally well. So this is a patient of a chronic CSCR with PED. So I think this slide actually depicts quite well. So this is a leak. So if you see from the early phase to the late phase, there's an increase in intensity as well as the size of the leak. But though it's a large PED, the size and the margins are remaining the same from the first to the last, though the intensity is increasing. So here you see, you can differentiate between the leak and the PED on the same image. And this is a patient who was symptomatic with the PED for over 3 years and then had a leak too. So I think we decided to do a PDT. Of course, before doing the PDT, we checked if the OCT angiography did not show any new vessel. So we did a reduced fluence PDT and the patient did very well, both visually, symptomatically, as well as on the anatomically. So very good. I think most results with reduced fluence PDT have been very good. This is another patient of chronic CSR. Again, the other eye was a lost eye, sick RPE because of advanced RPE, sick RPE. And this patient here, you can see all the changes. This is the posterior cystoid degeneration, the NSD here. There is sorry. So this is the autofluorescence showing the gravitational tracks and the RPE changes. And here you can see the pigmentary changes on the pseudo-colored photograph. The FFA and the ICG, there is a subfoveal leak, but more importantly, there are multiple areas of choroidal hyperpermeability that are seen around the disc and supratemporally. and dilated choroidal vessels that you see in this area here also. So not all the changes that we see with chronic CSR, the patient was given reduced fluence PDT. 3 weeks later, the fluid started resolving, and 3 months later, the patient was dry. This is the check FA and ICG, and you can see a complete resolution, not complete, but near complete resolution of the choroidal hyperpermeability. There was a recurrence in 3 years later, which is known, as I mentioned. So so at that time, we did not have PDT. This was actually just 6 months back. The patient came back with the posterior cystoid degeneration and NSD at the macula. So we're given intravitreal brolucizumab, and the patient responded well. So anti-VEGF in CSR, it has always been controversial because CSCR is not a VEGF-related disease. However, recent studies have postulated that anti-VEGF agents act by reducing choroidal hyperpermeability. Possibly the newer anti-VEGF, especially like aflibercept, brolucizumab, and faricimab, are much more effective than the earlier ranibizumab and bevacizumab that we had. Maybe one of the reasons is they have a dual pathway of action, and brolucizumab, possibly because of the high molar concentration, is much more potent. So this is a patient of a bilateral chronic CSCR. Left eye had poor vision because of sick RPE. So here you can see the advanced RPE damage. The right eye also has the RPE damage, but there is some sparing of this area. So this eye had the better visions, but with the increase in the cystoid spaces, his vision came down to 618 N18. He was quite upset. And so we did not again have PDT. We offered him aflibercept in both the eyes. Both eyes actually responded very well. So with CSCR, you're always wondering whether it's a drug that's reacting or responding, or is it just time that is making a difference. So we actually just, when he came back with a recurrence, we just waited for some time, and we realized that the cystoid macular edema had actually gone up. And then we again repeated an aflibercept, and the patient responded well. So he has been still continuing on aflibercept, and he requires it every 3 months approximately. So another line of treatments is the anti-corticosteroid treatment. It has been observed that CSCA patients commonly have endogenous hypercortisolism, and has led to trials exploring medications that target the cortisol pathways. Some of the drugs that have been included in the studies are ketoconazole, mifepristone, finasteride, rifampin, and anti-adrenergic drugs. Rifampin and sometimes ATT was often used earlier to treat multifocal CSR. I think there was a time when actually ATT was very commonly used, but I think especially rifampin, I think most pulmonologists felt that we shouldn't be using, because the way we used to use it, we wouldn't use it in the correct way. So they felt that probably it was not good and was leading to more resistant tuberculosis. So now I think overall the use of rifampin for CSR has come down. The mineralocorticoid receptor agonists, spironolactone and eplerenone, have been widely used to treat chronic CSCR. After few retrospective case series showed promising results. However, the Vichy trial, which is a randomized double-blind placebo-controlled, found no evidence of a clinically improved benefit of eplerenone for the treatment of CSC in terms of visual outcome, pattern of complete resolution of SRF, or the recurrence of CSC. This was a patient that we had of chronic CSR. He had good, relatively good vision, and he responded quite well to eplerenone. So eplerenone is given at a dose of 25 mg twice a day. It's important to do the kidney function test prior to giving eplerenone. It may also be a good idea to consult an internist before giving eplerenone. So he showed very good resolution after 4 months of eplerenone. Again, as I mentioned, we decided to stop the patient. So if you say this from December 23 to March 24, 4 months, he's done very well. And then in April, he comes back with fluid again after we stopped the eplerenone. We started eplerenone, and then the fluid resolved again. So I guess it was the eplerenone that's working. So some of the other modalities that have been tried is subthreshold micropulse laser. We haven't tried it, but a lot of people have shown good results with it. it acts possibly by causing increased expression of heat shock proteins, which may restore cellular function in the RPE. There's renewed interest in this as PDT is unavailable these days. Other drugs that have been tried but have not been very promising are carbonic anhydrase inhibitors, aspirin, anti-Helicobacter pylori treatment, and beta-adrenergic blockers. So I think one of the, just to put things in a nutshell, Stephen Ryan actually has given this kind of flow chart. So a person with acute CSC, so if symptoms are less than 4 months and there's presence of SRF and one or more leakage points on FA, and there are no sign of chronic CSC, then if there is actually, the patient is not symptomatic, there is no recurrent episode, there is no bilateral disease activity, and he's not very pushing for treatment, it's best to actually observe them for 4 to 6 months, and most of the time they'll settle down on their own. But if they don't, or if he's really if they don't and he's really either he's very symptomatic or it's a recurrent episodes, then the first ideal treatment is actually a PDT, but in the present era, it's not available. So I think a laser photocoagulation or putting the patient on something like eplerenone or maybe subthreshold micropulse laser is the option. If the patient settles down on that, then that's a very good thing. But if there's still persistent SRF on OCT, then again, go back to the imaging modalities, check if there's any OCT on the OCTA, if there's any CNV. Again, if there's a CNV, then you can just give an anti-VEGF and the patient will respond. If there's persistent focal or diffuse leakage, then again, go back. You can repeat the PDT, usually not before 3 months. You can do a subthreshold laser. We nowadays do give some of the newer anti-VEGFs, do focal laser also in such of these cases. Again, the protocol is pretty much same for a chronic CSC also, but of course, by definition, it is a persistent SRF on OCT for longer than 4 to 6 months. If there are one or more focal leakage points on FA, if there are hypofluorescent choroidal abnormalities. Again, the treatment of choice is ICG-guided half-dose PDT, and if there's still persistent SRF on OCT, check for CNV, repeat the PDT, or just observe. So in a nutshell, we'd like to summarize and say that CSCR is a common disorder. It's prone to misdiagnosis. So multimodal imaging is indicated in case of any doubt. Role of choroid and it being a part of the choroidal spectrum is something that we need to understand. The treatment of choice for acute CSCR is observation, unless, as I said, the patient is very symptomatic or he's a one-night patient, or if his job profile, indicates that we do early treatment. Otherwise, observation is the best option. Reduced fluence PDT was the treatment of choice for chronic CSR, but as in the present era, possibly focal laser or anti-VEGF or eplerenone would be the other choices. It's important, and probably this is the most important thing for CSCR patients, to counsel patients about long-term recurrences. Thank you.
Thank you so much, ma'am, for that wonderful talk on CSCR and showing us those beautiful algorithms for investigation and management of these cases. I'm sure the students are going to benefit a lot from the presentation that we have had. Sir, Cyrus sir, if you're there, would you like to put in some few comments before we move on to the question and answer?
Pranita, just hold on. Thank you so much, ma'am. That was really a wonderful talk. Initially, I had approached Cyrus sir for this talk. Then he told me that I am assigning this to the right person who can take care of this topic, and he was perfectly bang on. You really did great justice to the topic, and it's a very important topic. We get short case, we get long case for in exams. So thank you so much. Yes, Cyrus sir, your take.
No, thanks everyone. Thank you for a lovely talk, Charu, and thanks Praful and Pranita. I think it's been a very nice talk there, and I think few things we have to remember about CSR is that in the initial, whether in the acute stage, I think reassurance is probably very important to the patient, because as Dr. Charu said, most of these patients would settle down spontaneously. So I think, as we know, and as Dr. Charu has mentioned, that they are type A personalities. So I think one has to counsel them and reassure them that most likely this is going to get all right. And most of them do get okay and go into either cure or remission. So I think that is an important thing. But if they are going into the chronic stage, then we have to be again more kind of aggressive in the treatment approach, because we do not want them to get into the sick RP situation, as Dr. Charu mentioned. If we are very chronic and untreated, then even if the fluid has gone away, sometimes the vision would not improve because of the very sick RP that is happening. So I think there one has to balance the two things. And as far as PTT is concerned, hopefully we hear that possibly we should possibly, with maybe before the end of this year, have some access to PDT, which may be kind of manufactured within the country. So let us hope, because that really is a game changer for chronic CSR. I think the other options of eplerenone and the micropulse laser and all of that, but I think there's no doubt that PDT has been really the most effective treatment for those patients. One more little thing about focal laser, which again Dr. Charu mentioned, that's important. When we should not hesitate if we have extrafoveal leaks. Doing a focal laser with an anti-VEGF injection usually gives a permanent cure to these patients. The other thing, remember that when you're doing a focal laser, this is not to be a heavy, it has to be relatively mild burns should be given to these RPE leaks that we see. Because giving heavy burns can sometimes, in fact, trigger CNV formation. So that is one thing we have to be careful about. That's all that I have to.
For Anita and Dr. Anita, please check if there are any questions by the residents.
Yes,
Ma'am?
sir. There are a few
Yeah.
questions. So one of the resident has asked that what is the risk of a recurrence in the same eye which has had a case of acute CSCR?
Yeah, I think the recurrence rate is quite high. Oh, sorry. I think I'll have to. Should I just go to?
I think you have to take out two devices. You have to mute
I
one.
think I'll have to switch off this.
Yes. You can just mute. No need to switch it off.
Yeah, now it's better.
Yes,
Yes,
ma'am,
ma'am.
it's
Yeah.
fine.
Yeah, so I think the recurrence is nearly 30 to 40% in patients of CSR. So even after a focal laser, even a few months or even years later, patients come back. Even after PDT, actually, after a few years, we often see patients coming back because actually there's an increase in the choroidal hyperpermeability. As I said, the area of increase is much more wide. So it's a very widespread disease. So you are only treating a certain area at the time, whether you're doing it with laser or you're doing it with PDT. So it can recur, and yeah, I think it's nearly 30 to 40%.
Ma'am, the same student has asked that what is the risk of involvement of the other eye? What should I explain to my patients when they have an acute CSR in one eye? In one eye.
Again, so earlier they said the bilaterality was just 10%, but now I think more and more studies are coming on that the other eye involvement is nearly 20 to 30% possibly. But yes, I think maybe you can still say that. I mean, I guess they are type A personalities and stressful patients, so you can tell them that the other eye may be involved, but I don't think we should be scaring them. I think more from the psychological point of view is. But yes, we have to be prepared that the other eye. So it's a good idea to give them an Amsler grid. So that's one way of, so that they're aware of it, but not to overemphasize if I were to take it, from the psychological point of view.
So another student has asked that if we get a case of CSCR in our short case, and my examiner asked that what are the systemic investigations that should be done, what should be said at that note?
No, I don't think we ever advise any systemic. Of course, unless the patient has, like, you can ask if it's a female patient, you can ask if there's any hormonal imbalance that has been there, or there are are they menopausal, or if there are other any other point of view. But if you're suspecting a Cushing syndrome, or then of course you have to get the endogenous steroid levels done. So, but otherwise, we do not advise all CSR patients to get any systemic examination done. And as I said, if you're putting the patient on eplerenone, then you need to get a kidney function test done.
Dr. Ankur is also there, and Neeta ma'am, if there are any questions from your side to ask, Dr. Ankur?
Just two questions. One is, how long can we put this patient of chronic CSCR on eplerenone? How long can we keep treating this patient?
So
if there is still persistence of the subretinal fluid.
So usually you don't like to put them for more than 6 months. And even for that, you should be in touch with the physician. But there have been some patients when we've been in touch with the physician, and we've been keeping, you've been monitoring their kidney function tests. So even up to a year and a half, we have kept a few patients. But yes, ideally, I would say 4 to 6 months. But even at that time, make sure that you get the kidney function test and you're in touch with the physician.
And any role of topical carbonic anhydrase inhibitors in treating CSCR?
No, I think they have been tried, but really we have not found it to be effective.
I think there are few questions from my residents, because this is a very important topic for short case. So the old examiner, they are very fond of asking this question. Do you need FFA to diagnose a case of CSCR?
I guess, if you want to confirm the diagnosis, you will need an FFA. Only on the basis of an OCT, you can never be 100% sure it's a CSR. So for a confirmed diagnosis of CSR, you need an angiography.
Okay, how far is avoiding smoking useful? I think there are few studies, they suggest tobacco use should be avoided in CSCR patient. Is there any role of that or what?
So again, I think none of them are direct, but since it's a type, it is a type, it's related to stress levels. So the stress levels leads to increase in the endogenous steroid levels. So ultimately it is important to decrease stress, whether it's by lifestyle modifications, whether it's the yoga practice or something, but it's not like directly stopping smoking is going to help. But lifestyle modifications are going to help the patient. But there's no direct correlation that if you stop smoking, your CSR will become okay. No, that's not true.
Thank you, ma'am. I think that's it from my side.
Ma'am, there is one question.
Yeah.
So, in typical CSR patients, ma'am, how frequent you have to see the patient, and while counseling, how much duration we should usually tell the patient that it will resolve on its own? So, what is the duration and how frequent we should see the patient?
So I think the duration of usually 3 to 4 months, you'd have to counsel the patient. I mean, I think that at the first visit itself, that you tell the patient that it's a disease, it's a self-limiting disease, and it will take 3 to 4 months to resolve. But I would not, like, after the first visit, I would definitely like to see the patient after 6 weeks, because a month to 6 weeks, you want to make sure that it's not increasing. Because if the fluid is increasing, then we may need to rethink whether the diagnosis was correct at the first time, b, whether you need to give treatment early. So I think always a good idea to recheck again after a month to 6 weeks, and of course, tell the patient that it will take 3 to 4 months. Also, you get to know the trend, whether the fluid is decreasing, increasing, remaining the same, because that also will help us to counsel. So if the fluid is increasing, then I know I need to do something active. If the fluid is the same, I'll probably again tell the patient that we may need to do something active because leaving the fluid too long may lead to chronicity. But if the fluid is decreasing, I can reassure the patient that he's on the right track. So I think that helps.
And we should repeat the OCT also in all the
Yeah. When
visits.
we call back after a month, 100%. That's the only way we are going to know.
Yes.
Yeah.
Thank you, ma'am. Yeah.
Okay.
I guess there are no more questions. So, just an update to all our students. This program is being live telecasted on 2 platforms. One through DOS YouTube channel that any audience can watch. The second is for audience group through the Entered platform. So, if you are a student, you want to interact directly, please register and then participate, and also join our DOS PEP group. That is where we keep on updating all this thing. And thank you, Charu ma'am. And this is a small appreciation from Delhi Ophthalmical Society. And we will give you a frame certificate at our annual conference, which is going to be on 13, 14, and 15 June 2025. And Pranita, Anita, you can now conclude.
Thank you. Thank you, everyone, for being with us here. And thank you, Cyrus, sir, for sharing your valuable time, and Charu, ma'am, for that wonderful lecture, and Anita, ma'am, for being there, and Dr. Ankur, and Praful, sir, always for encouraging us for all these classes. And we were fortunate, we had 379 live views today for our class. And as sir has already said, that it is also available on the online repository for further views. And with that, we'll come to an end of this class. And thank you, everyone, for being with us here.
Thank you. Thank you, Dr. Pranita. Thank you, Dr. Praful. I think, thank you. It was nice
Thank
to
you,
be a
ma'am.
part
Thank
of
you,
this.
Cyrus sir.
Yeah. Thank you, sir.
Thanks,
Thank you,
everyone.
ma'am.